team. I'm staying on the left side of the heart for the time being. You've heard about the aortic valve in the last session, so we're moving on to the mitral valve. So pleasure to be here. These are my conflicts, nothing relevant to this talk. So we started a bit late, so I'm going to not hang around in the interest of trying to keep on time. This is what I'm going to try and cover in the next half an hour or so. So we're going to have a very quick overview on mitral valve anatomy. You see that more often than I do, I suspect, in vivo anyway. Obviously going to concentrate on mitral regurgitation. I'm going to go through some of the basics in terms of classifications, why it's important to classify MR where possible into primary and secondary, and then of course methods of assessment, which is really what I do for a living, and there are various imaging modalities. And I'm going to finish by talking a little bit about evidence for intervention and when to pull the trigger, so to speak. So I don't suppose there's many cardiovascular images in the audience, but this is probably worth a read. It's an American document. And I think the way I view the mitral and tricuspid valve, for that matter, has changed a lot, even in the last 5 years since turning consultant. And a lot of that's been because of improvements in structural heart disease, so I get called to the cath lab a lot for edge-to-edge repairs, and I have a much better understanding now of mitral anatomy, I think, than I did as a final year registrar. But this document sets out quite nicely what we should be aiming to achieve when we assess mitral valve in fullness. So I've pinched some of this talk from that document specifically, and this slide in particular. So again, I don't want to spend too long on anatomy because you see this in theatre more than I do. I don't get to theatre as much as I'd like. But just to orientate you, so this is what we're able to create now very nicely, and surgeons like this, I think, because it's not too dissimilar to what you see with your own eyes when you get in there and open up the valve. So we often talk about trying to produce this on 3D views. So obviously anterior leaflet, posterior leaflet, and you'll be familiar with the segments and scallops that are involved. And one of the points I wanted to make is that this red dotted line, so-called hinge point, is not at the same level as the aortic valve annulus. So that's that difference between that area where the mitral valve actually hinges at the true annulus is known as the mitral aortic curtain. And that's relevant because when you come to annular sizing, now I've stopped reducing. I talk about whether the annulus is dilated or not, but I know, talking to Mr. Bradford, that he doesn't look at my mitral valve annulus dimensions on 3D echo, and you size that in theatre. But we still take pride in looking at mitral valve dimensions. This is quite a nice 3D representation looking up from the left ventricle. This is actually explanted pig heart that's been reanimated. And this is taken from the University of Minnesota's work. But I think it just shows you that really, that area that I wanted to stress, that aortomitral curtain, there is a distance between the aortic valve plane and the mitral valve. And I think this is useful just to realise that the close proximity of these two valves, which can sometimes cause problems, potentially depending on aortomitral angulation, which needs to be thought about. So let's focus on mitral regurgitation. So back to basics. So as you heard from my last talk, I still find Carpentier classification incredibly useful, and this was what it was made for originally. Carpentier was a surgeon, as you know, and I find it really helpful to still use this, and I still put this in conclusions in my TOE reports. So just to recap, so type 1 is effectively a form of functional mitral regurgitation. So remember that your mitral valve is not just, the annulus itself can be dependent both on what's happening in the atria but also within the ventricle. And so if you have dilatation of either of those structures, whether it be the ventricle or the atria, that will result in annular dilatation, and you'll have loss of that saddle shape, annulus, and that leads to tension on the valves, and you will tend to see a more elliptical type jet coming through. So rather than a central orifice, but generally speaking, this is a relatively central jet. And so we see it predominantly in patients a lot now with so-called atrial disease with atrial fibrillation, big dilated left atrium, restrictive cardiomyopathy. Type 1 does also cover endocarditis, so that's because the leaflet's inferior and normal. The leaflet motion is normal, but you've got a hole in the leaflet from endocarditis. But generally speaking, type 1 for me, I think of annular dilatation. Type 2, so this is bread and butter, this is what we fight over at the moment in MDT quite often, because actually both clearly our mitral valve surgeons have wealth of experience in dealing with this disease. So this is fibroelastic deficiency, in the early spectrum right the way through to Barlow's disease. And type 2 refers to excess motion of the margin of the leaflet segment above the annular plane. So that's a prolapse. And if you've got a flailed segment with associated chordae, that's more of a concern and have a lower threshold for indication for operation. Then moving on to type 3A and type 3B. So type 3A, that's where you have restriction in leaflet motion both during diastole and systole. So classically that will be a rheumatic mitral valve. But don't forget other causes. We've been caught out in the past, not that far long ago. We looked back through a case of a lady who had a bypass for angina variant breathlessness, had a number of procedures, and in the end we realised that actually she had radiation damage to her tricuspid valve rather than mitral valve, and that was what was causing her symptoms. So think about radiation. Parkinson's drugs occasionally can be implicated. And then type 3B, so classically this is called ischemic MR often, which I don't really like that term, because for me ischemia is a transient reduction in blood flow that then normalises at rest. So you do sometimes see that phenomenon, but that's incredibly rare. But really what this means is the patient's had an infarct, usually in the circumflex territory. They've got tethering, thinning of the infralateral papillary muscle, and that's causing tethering on that posterior leaflet. So you'll tend to see a more eccentric jet of MR directed in that same area. So rather with a type 2, well, you'll see, we're going to talk more about that in a minute. So in terms of the patterns, you can see here in this left atrium, clearly dilated left annulus, and we've discussed this already. So this is a fairly central jet, usually easy enough to see, and it relates from issues around annular dilatation, but then that also has an implication on restriction of the valves too. On to type 2. So as we've talked about, this is excess motion of the margin, so this is prolapse. And this can be starting really with just fibroelastic deficiency affecting perhaps just one segment, right the way through to a more extreme version where you've got multi-segment prolapse and a Barlow's valve. And this is just one example. This is a fairly nice example of a P2 prolapse and with a flail segment. And you can see there's probably also prolapse involving part of P3, but the flail is in P2, that's where your money is. And there's clearly a lot of mitral regurgitation, and that will be directed anteriorly. Alongside that, loss of saddle shape and annular flattening all out. And then this is an example of rheumatic mitral stenosis. This patient did have a degree of mitral regurgitation too, but a predominant pathology was stenotic valve. And you can see there's quite a lot of calcification and mitral annular calcification as well in this patient, which is contributing to that restriction. And then just to recap on type 3B, so we've talked about this. Generally speaking, the type 3B ischemic MR, usually in the context of an inferior infarct, this is not a terribly good example because usually what happens is the MR comes this side because of this restriction in the posterior valve leaflet. So the posterior valve leaflet's tethered and doesn't have normal leaflet motion. You can see more central jets when you've got a non-ischemic cardiomyopathy, so you've got LV dilatation for other reasons. And again, that's where there isn't a true abnormality of the mitral valve leaflets themselves, but because of ventricular dilatation, that results in secondary mitral regurgitation. So closely related to that classification, the guidelines focus very much on defining what's primary and what's secondary, and I think One of the points I want to get across to this audience is that even for an imager like me, I find this difficult, because it's true to say that in the majority of cases there will be a predominant mechanism, but this is almost too simplistic. So in any patient with fibroelastic deficiency who's got a PT prolapse, they will inevitably get annular dilatation with time, with chronic loading of the left atrium, with chronic MR. So there will be a type 1 element, I guess, but I think it's important to try and work out which is the predominant mechanism, because that's going to determine how you manage the patient subsequently, and we'll come to that when we go through some of the guidelines around managing this. But essentially, primary MR, just to make clear, is characterised by a primary lesion involving one or more components of the mitral valve apparatus. Secondary MR is a very, very different beast indeed, and I think there is far less good evidence that these patients will do well from mitral valve repair surgery outside the context of revascularization. This is where the valve leaflets and chordae are structurally normal, and the MR results from an imbalance between the closing and the tethering forces secondary to alterations in the geometry of the left ventricle and the left atrium. So it's a prop disease of the left atrium or the left ventricle, not inherent to the mitral valve. This is just to remind me to tell you why I think 2D echo is really challenging. So this is a 3D reconstruction of a patient with secondary MR, and you'll see that their jet is not hemispherical, is it? So a lot of our 2D measurements on transthoracic echo are based on a lot of assumptions which are wrong. Clearly, this jet is ellipsoid and crescentic, so it's right the way through the mitral annulus. So if you just look at this in one plane on a 2D echo, you're going to underestimate the degree of MR. And that's why this is probably, for me as an imager, the most important thing that we've done to change our assessments of mitral valve. So this is our bread and butter, and actually for me, if I can get a good quality commissural view with a sweep, so-called commissural sweep, we can look at the entire anatomy of the mitral valve and pathology in a space of about 10 seconds, if you're going slowly. So, just to orientate you, so this is at 60 degrees, and we've started, we're using X-plane and just sweeping through, so obviously the top's without colour, and that tells you a lot in this patient. So this is a nice example, if I freeze it at the right time. When we get into the twos, which is about here, oh, sadly didn't work. Anyway, I'll just let it play. But when we get to the middle of the valve, we're crossing then A2, P2, okay? So we're starting at the threes, and we're sweeping across anteriorly, or anterolaterally rather. So we're going from threes to twos to ones. And this is really useful. Or if you like, in interventional jargon, we're going from medially to laterally if I'm in the cath lab with Dr. Nadir and Professor Deshi. So we have to talk the same language, and that's important. So this is a nice example of severe MR secondary to a PT flail. So this patient actually was deemed too high risk. I think the patient was in their late 80s. They had quite bad emphysematous lung disease on top of this. And in the end, after discussion in our heart valve MDT, which I must say usually includes, well, does include, an anaesthetist, at least one, if not two surgeons, two interventional cardiologists, at least one imager, and in an ideal world, Dr. Lim as well. He's one of our advanced heart failure cardiologists. So we like to try and, I think that's important because everyone provides added value to that. But in the end, the decision was made that this patient was deemed to be surgically too high risk, and we decided actually we could get a pretty good result from an edge-to-edge repair. So this was before. This is stopped. But again, you can see the P2 and you can see the caudal tissue prolapsing back. into the left atrium, and the systolic flow reversal. So this is a pretty hard sign. If I see systolic flow reversal in the pulmonary veins, I'm pretty happy that they're severe MR. And then this is what they were left with. So in the end, we ended up putting no less than 3 clips on the device. And this was one of our earliest cases. But despite that, this is almost like an alveolar stitch, isn't it? But a big stitch. And you basically left with 2 orifices either side of that. Mean gradient was left behind was 2 millimeters mercury, and this was our end result. So we were pretty happy with that. And then just to show you a case of rheumatic mitral stenosis. So again, this is another patient that came through our MDT, and this is just an example of the sort of thing that we're able to achieve with good quality 3D images. So we're lucky if we can get good enough quality 3Ds. We can do limited areas, which is still the gold standard for me for mitral valve assessment in terms of stenosis. And this patient underwent balloon mitral valvotomy with good result. So let's talk a little bit about assessing MR. So for me, when I think of assessing MR, I want to know 2 things: severity and mechanism. Okay? But not everyone can have a TOE, a CMR, an exercise stress echo, but certainly that is potentially required in some patients. But the point of this slide is to show you where we head. So almost all patients will invariably have had a transthoracic echo, which will raise suspicion about mitral valve disease. And if they're good quality pictures, often we can happily be confident that there is severe mitral regurgitation if we see presence of a flail, large central jet, being contracted more than 7, high forward flow velocity with E-dominant pattern, systolic flow reversal, if you're lucky enough to be able to get pulmonary vein seen on a transthoracic echo. Not always easy, not in a Birmingham population with a BMI of over 35 on average, and evidence of elevated PA pressures, then you can be confident. But infrequently we're in this area where we don't quite get good enough quality pictures, or we may get some discrepancies in values. And there's a lot of debate about cut-offs around severe versus moderate MR depending on the mechanism, which I'll come to in a bit. But the point of this is to say that actually, not dissimilar to what I told you for the aortic valve, if you've got a patient in front of you who's breathless and you can't explain it any other way, and you've not seen good enough quality images, then have a very low threshold to ask someone like me to do a TOE. And if the TOE still doesn't give you a clear answer, then think about other modalities, particularly for mitral valve. So I occasionally use exercise transthoracic echo. If patients aren't breathless at rest but breathless on exertion, it makes sense to stress them, doesn't it? And see what's happening to the mitral valve. And there's some quite good exercise echo data. I'm not showing you that today, but Lancelotti's published a lot of nice papers looking at exercise-induced pulmonary hypertension in the setting of severe MR in patients who claim to be asymptomatic, and that's a license to intervene. So I've shown you some TOE, but I think it's worth highlighting that there is also a role of CMR, partly because this comes from Birmingham group as well. I think it's nice to show you. And there is increasing traction amongst images that actually mitral regurgitation can be pretty well quantified on MRI as well as on echo. And when is it useful? Well, like I've touched upon, I think if there's discrepancy between clinical presentation and your echo, what else does MR offer you? So I used to spend my life as a PhD fellow drawing circles around the heart, but I'm delighted to say with the advent of AI, I can now do this with the touch of a button in about 5 seconds. And you get very reproducible, automated LV contours in end diastole and end systole. So MR is by far and away accepted as the gold reference standard for LV volume quantification and function. And in fact, the interstudy variability between operators is very good. We can also assess the amount of blood exiting into the ascending aorta. So this is a flow map. So your stroke volume is effectively your area under the curve here. So this is flow mils per second over time. This is something called a flow map. And we do this routinely actually, because it checks, also it's a check for me about stroke volume in any patient, but particularly in MR, what you're effectively doing is you're generating EF, EDV, ESV from your short axis stack. And obviously if some of that blood is going back into your left atrium, not all of it's going to end up in the aorta. So the difference between this stroke volume and the stroke volume you've generated from your contours is your MR regurgitant volume. And we don't do this routinely, but this is just a nice example of a patient with a very abnormal mitral valve with a significant prolapse, and on this case you can see aliasing. So there's a very eccentric MR jet hugging the anterior mitral valve leaflet here because of a big prolapse in the posterior leaflet. And we don't go to the trouble of this, I have to say, because invariably patients have had a TRE, and I think TRE still does this better. But you can orientate cines through the various scallops if you so wish, and that's what's been done here. So you can see there's reasonable coaptation at the 1s and the 3s, but a big prolapse of PT. So, not dissimilar to the aortic, you know, the guidelines still talk about two-dimensional measurements of the ventricle. I think we should go beyond that, really, and I'm hoping that we'll see changes in that soon. We've got pretty good reproducibility with 3D LV quantification on echo, but also on CMR, and I think that will come. One of the big questions is around time to go, and quite often we will track patients who claim to be asymptomatic and watch them very closely, and as soon as you start to see dilatation in the left ventricle, for me that's probably a signal that this patient's going to do badly if we don't intervene soon. In terms of looking at the variability between operators, again this is just one paper, but would suggest that there's probably less variability in terms of CMR quantification, so that tends to be more reproducible between operators. And there's a growing data on the prognostic value of regurgitant volume assessed by CMR. So this is an old paper, and you'll notice only very small numbers. And one of the problems we have is that this is, of course, observational data, and this is just looking at survival and then time to intervention. So it's not surprising that these patients get intervened on because they've got a much bigger regurgitation fraction. But it's interesting data, and I think it does provide complementary value in certain cases. One of the other advantages of CMR is that it allows you to perform what we call, as images, tissue characterization. So you can get information around scarring, and there's some quite nice work looking at in young patients, often females with mitral valve prolapse. There's been some work from Christine Basso's group looking at non-ischemic as well as ischemic scarring and the infralateral wall being associated with mitral valve disease. So that probably adds a little bit in terms of further workup and in terms of etiology, and occasionally we'll find incidental infarcts. So in terms of the relative benefits, I still think echo is very much your first line test, your go-to test. But MR severity assessment can be helpful when there's discrepant data, particularly if there's eccentric jets. We've not talked about prosthetic valve disease, but in patients with prosthetic valves where imaging can be really challenging on the transthoracic echo, then that can be another area where MR can help. And I think, you know, there's still a lot of work to be done in terms of automated quantification. So in the last 5 years, we've gone from doing 2D measurements routinely now to 3D measurements, and I think that's going to be the way forward, but I'm hoping it's going to be easier and easier and more automated with time. So I've covered this already. When to consider MR? If you've got multiple MR jets, adding them all together, it's very difficult on echo. But if you can just look at forward flow stroke volume on an MRI, that gives you a very helpful overall view. And again, chamber size and function. I'm going to just skip through these, but these were a couple of examples where there were discrepancies between echo and CMR was helpful. but I want to get on to evidence to intervene because I'm conscious of time. So it's worth pointing out there are one or two discrepancies, but they're fairly minor between US and European guidelines. But the thing I really want to highlight is this one. So there's no doubt in my mind that at the moment patients with severe mitral regurgitation that's primary need to go and see a surgeon, and for me, if they're fit enough for surgery, they should undergo surgery, preferably mitral valve repair, and I'll show you a little bit of data on that. I probably don't need to tell this audience that you'll be well aware that the outcomes based on some good registry observational data suggest repair is by far and away the better of the two options in patients where it's feasible. But the interesting thing for me is this. So the Americans seem to have given a slightly higher 2A level of indication for TEER in high-risk patients with primary MR. And that's interesting. We'll come back to that in a minute. But really, TEER was born out of this. So, you know, the COAP trial, we'll touch on some of the trials in a minute, really came from this area in patients that probably we don't think benefit necessarily as well. The importance of goal-directed medical therapy, I have to remind my interventional colleagues, actually, is the patient on Entresto? Are they on a beta blocker? Are they on an SGLT2 inhibitor? Are they on a mineralocorticoid receptor antagonist? That's why we have Cern Lim in the room, because interventionists like surgeons like operating. So we have to just check and say, well, actually, are they yet on goal-directed medical therapy? And then you can move into other, look at other options. So ESC guidelines, this is what to do, what's felt should be recommended in patients with primary mitral regurgitation. So as you've heard, mitral valve repair is the recommended surgical technique, and the results are expected to be durable. Personally, I think this is too late, but you know, we don't have the evidence yet for volume chain quantification, but if you've got an end-systolic diameter of greater than 40 millimetres, I think this is an important thing to highlight, and it's not actually always that well known amongst my cardiology colleagues. If you've got an ejection fraction that's calculated at less than 60% in the context of severe MR, that's impaired left ventricular function by definition, and they have a class 1 indication. Some of the more nuanced changes that have happened in the last 10 years, so presence of atrial fibrillation gives you a class 2A indication, presence of pulmonary hypertension at rest, but also on exercise now there are data supporting class 2 indications to move on that. And I think this is important, when surgery can be offered in a heart valve centre and a durable repair is likely, even in low-risk asymptomatic patients, so these are patients that are yet to say they're breathless, should be offered surgery on a 2A/B setting. So, you know, that's worth just highlighting. By the time you've got symptoms, to me, those are the patients that you operate on, and then you see a fall in their ejection fraction, which we're trying to avoid. So, I think I've more or less covered that. Secondary MR is a bit more tricky, I think. So, I'll come over to here. So, I've stressed the importance of goal-directed medical therapy. And MR is dynamic. There is absolutely no doubt in my mind that we've seen patients that have had a transthoracic echo in the context of severe LV impairment. They've been started on goal-directed medical therapy, and in 3 months their MR's gone from severe to mild. And it's because of ventricular remodeling. So there's a question of timing to consider with secondary MR. Obviously, if the patient has coronary disease and they're undergoing revascularization and their MR is secondary to type 3B, then absolutely, I think you've got a license to intervene in those patients. But in patients who who don't have an indication for revascularization, these are the patients that arguably you should be considered TEERing on the basis of a couple of trials I'm going to show you in a moment. These are the American guidelines. They say the same things effectively. It's just to highlight, again, that the Americans give transcatheter registration repair as high as a 2A, whereas at the moment in Europe it's still a 2B for primary MR. that probably will change. And patients have to be at a high or prohibitively surgical risk for them to come to us. In terms of secondary MR, again, goal-directed medical therapy. This is interesting. So these guidelines talk about an EROA of 0.4, but you'll find that in the trials that have just been presented at ESC, the mean EROA in the ReShape heart failure trial was about 0.28. So there is a lot of talk amongst the community about what defines severe MR in secondary MR, and I think that's difficult. Ejection fraction more than 50%, then there's a 2B indication for mitral valve surgery. If you've got impaired LV function, persistent symptoms despite optimal therapy, these are big diameters, and potentially, if you've got an end systolic diameter of less than 7 centimetres, I've not seen many ventricles that big, and you've got a 2A indication. Obviously, if the patient's going to have a bypass, please do put in a ring as is done. So, I pulled out these data because I think this is where this is just worth stressing to a surgical audience. I am a friend, not a foe, and you guys have got 20-year data, so we don't have that in TIR at the moment. And certainly, if you've got evidence of durability. So, looking at this, for me, this is pretty impressive. In terms of outcomes, you've got pretty low rates of mortality, but still, the key message for this slide is that patients that undergo mitral valve repair tend to do a lot better. These are propensity score matched cohorts, and even after matching for various other factors, there's a significant mortality benefit from repair over replacement. This is more of the same. So again, big surgical, multi-centre prospective registry effort. And this is looking at results from mitral valve repair for regurgitation due to leaflet prolapse. The thing though that strikes me is that there's pretty good durability here. 1 in 8 had recurrent, either moderate or severe MR within a median survival, I think, of about 5 years. No, that's an exaggeration, over 20 years, apologies. So 1 in 8 have recurrence of moderate to severe MI over 20 years, but as many as 1 in 5 had moderate or severe TR in association with mitral valve disease at that length of follow-up. So there's a small proportion, but generally speaking, in my experience, if the patients don't have an early dehiscence, they do very well for many years. This is just to highlight to you. I think it's intriguing. Maybe we'll discuss what this is likely to show. But I think we're set. I think the interventional cardiologists, I think, are set up to fail here. But we'll see. So this is an ongoing trial looking at primary mitral regurgitation, looking at TIR head-to-head against surgical repair, and it's ongoing in terms of recruitment. I think we're going to watch this with great interest, but it's ongoing at the moment. A couple of trials that have just been published, just to give you a bit more of a contemporary flavour to this. So this was a big hotline session. The ESC Congress was huge in London. This is the biggest cardiology conference in the world. There's something crazy like 20,000 people attend this from all over the world in London a couple of weeks back. And this was presented, so this was the Matterhorn trial, and this was designed as a non-inferiority trial to evaluate mitral TIR versus surgical mitral valve repair in patients with secondary MR, so this was secondary, not primary MR. But you can see that actually, if anything, TIR did pretty well and demonstrated clear non-inferiority. So for patients with secondary MR, probably this is supportive that edge-to-edge is looking promising. And again, another trial looking at the MitraClip, so that's an Abbott device, which was the first device really used in any great numbers. big multi-centre trial looking at patients with heart failure with moderate to severe MR. But the thing I want to highlight to you is this: moderate to severe. So we've got mean effective regurgitation in the office area, and people that are randomised to trials there is 0.25. That's not a lot of MR for me. So that's a bit worrying. And yet they've seen significant benefits. I admit that you can't have a sham control for this trial, but so there is a degree of bias associated with that. But nonetheless, seems to be significant improvements and reductions in hospitalisation for heart failure, composite endpoints of heart failure, death, and cardiovascular cause. And actually, we forget about this a lot. Cardiologists, we're not terribly fluffy, but actually making patients feel better counts a lot for patients if you ask them. And then this was also presented at ESC, so this was a big meta-analysis where they hashed together all the data from the secondary MR trials. So I think in total we're looking at, let me just recap, 614 patients in cohort, 304 in mitral FR, and there were 505 in the Reshape HF trial. So if you add all that together, overall there was a trend that just met significance in terms of reductions in death and all heart failure hospitalizations through 24 months. Just to reiterate, this is secondary MR, not primary MR. Didn't quite meet significance in the meta-analysis for cardiovascular death out to 2 years. And these are 2-year data as well, so relatively short-term follow-up. But there was a definite improvement in functional capacity as assessed by 6-minute walk distance. So to conclude, I think what's really clear for me as an imager that I need to help better understand why that patient's developed mitral regurgitation, because if it's primary, your downstream treatments are going to be vastly different from whether it's secondary. I think understanding the true hemodynamic consequence of the MR is key, and I'm just going to leave you with 5 take-to-work messages. So hopefully I've convinced you that 3D TOE is the way forward in terms of being more accurate for quantification and assessment of MR. CMR can be useful when you've got discrepancies between imaging modalities. These in red are the key things for you to remember as a surgeon. If you spot any echo reports where the EF's less than 60%, you can tell your cardiologist they've got a class 1 indication for surgery. Surgical MV repair is undoubtedly the preferred method of treatment for primary MR if an effective and durable repair can be achieved. Even in patients with asymptomatic disease, they'll have a 2A indication for that. But I think transcatheter edge-to-edge repair is very exciting. It's very early days. We don't yet understand the true durability of this procedure, but I think it certainly is complementary for patients in terms of reducing mortality and morbidity in patients with heart failure and secondary MR. Where its place will be in terms of primary MR, I think remains to be seen. Thank you for your attention.